All right, part 2 of your favorite chapter and mine, chapter 41, Obstetrics. So we're going to carry on. We are on the slide starting at cardiac conditions. So one thing we want to do is determine the nature and treatment of any heart condition. So some of the things are, we want to look at cardiac medications that they might be taking, diagnosed with dysrhythmias or heart murmurs, history of rheumatic fever. Maybe they were born with a congenital heart defect. So, it could be benign, completely asymptomatic and not a big deal, but with the added stress of pregnancy, it could become an issue. And then, of course, episodes of dizziness, lightheadedness, syncopal episodes with pregnancy, and that could be a sign, as you know, of dysrhythmias that could be really dangerous during times of labor. So peripartum cardiomyopathy, it is an uncommon form of heart failure, but it happens during the last month of pregnancy or up to 5 months after giving birth. So there are a few different risk factors that are associated with that. Obesity being one, history of cardiac disorders, use of certain meds, smoking, alcoholism, multiple pregnancies, poor nourishment. This can also be easily confused with eclampsia. Hypertensive disorders, so chronic versus gestational hypertensive. These hypertensive disorders are a major cause of mortality and morbidity in pregnant women. So previous hypertension or borderline hypertension may be exacerbated by pregnancy, meaning if they came into this deal already on the verge of or borderline hypertensive, or they had been diagnosed with hypertensive, then being pregnant can make it much worse, can exacerbate this issue. So chronic hypertension, we've talked about this, but blood pressure equal to or greater than 140/90, and this is consistent, not just a one-time deal. Exists prior to pregnancy, occurs before the 20th week of pregnancy, or persists postpartum. Now, what you have here is you have an increased risk for stroke or other cardiovascular problems. And then you move over, you have gestational hypertension. So that's also formerly known as pregnancy-induced hypertension. And this guy, he develops about, after the 20th week of pregnancy. It resolves spontaneously at postpartum. Risk includes obesity and glucose intolerance, but it can be an early sign of preeclampsia. So since we mentioned preeclampsia, let's just go with that. Preeclampsia occurs in about 8% of all pregnancies. You have some different risk factors. First pregnancy before the age of 20, advanced maternal age, history of multiple pregnancies, chronic hypertension, renal disease, diabetes, being African American. Those are all risk factors that are included in preeclampsia. Now you guys should remember preeclampsia. Preeclampsia manifests after the 20th week with a triad of symptoms, including a few different things. Am I on the right one? Here we go. So edema, usually of the face, ankles, and hands. Gradual onset of hypertension, and then they have protein in the urine. So they have some protein that's spilling over into the urine. Other symptoms, severe headache. So again, you can see some other symptoms that should make sense to you, considering we're talking about high blood pressure. So severe headache, nausea, vomiting, agitation, visual disturbances. Those are all fairly normal side effects or symptoms of high blood pressure, and then also potentially a rapid weight gain. So preeclampsia, it may require emergency hypertensive medication, so things like labetalol or hydralazine also. So, be somewhat familiar with those guys. Other conditions that may accompany preeclampsia include liver or renal failure, cerebral hemorrhage, abruptio placenta, and then a HELP syndrome, which is hemolysis, elevated liver enzymes, and then low platelets. Talking about some seizures. Treatment is difficult because drugs may cause fetal distress. Remember, we've mentioned this and you already know this, but whatever you give mama, there's a really good chance it's going to get transferred to baby. If it can cross that placental barrier, then baby is going to end up processing it as well. That's why it's so bad when you have these calls with, babies that are born with meth going, or especially opiates, because they really experience a lot of respiratory depression. But these seizures, we're talking about seizures, so they can be caused by hypertension, toxemia, preeclampsia, or even a pre-existing seizure disorder. So the treatment is difficult because the drugs normally used for seizures may cause fetal distress, so we have to start looking at different things. Magnesium sulfate is recommended, especially with eclampsia. High flow O2, of course, is needed to counteract hypoxia. Now, you do have some potential complications. Abruptio placenta, hemorrhage, you have DIC or disseminated intravascular coagulation, and up to and including death. Now, the old diabetes, or diabetes, as some of you may call it. Gestational diabetes, mellitus, inability to process carbs during pregnancy. This is when, if you've been around a pregnant lady, or you're married to one, or just know one, they're always doing like the glucose tests and all of that, wanting to see how their body is processing these carbs. So that's what we're talking about, finding out if they've developed gestational diabetes. So the treatment for gestational diabetes, it includes diet control, oral hypoglycemic medications. Because what happens is you have this increased maternal insulin production. It causes an imbalance between glucose production and insulin supply. So the thing about this is the patient may be asymptomatic, or they could exhibit the same signs as a patient with diabetes mellitus. So diabetes may be affected by pregnancy. It may manifest itself as either hyper or even hypoglycemic episodes. So because those oral hypoglycemic agents can affect the fetus, insulin-dependent diabetics may need to adjust their dosages during pregnancy. So because everything, food, water, medications, everything goes to baby, at least for the most part, then we've got to think about that. So if we're going to throw in some insulin, or mom is going to throw in some insulin, then we need to make sure that there's going to be an ample supply of sugar or glucose for baby. So pregnant patients with a history of diabetes should have a blood glucose level test with a glucometer. Now, talking about pre-hospital management, obviously some of these things that we're pretty familiar with already. A lot of general supportive care, high flow O2, IV fluids, administration of D50 if they are hypoglycemic. What's gone on routinely with hyperglycemic is we're kind of what I like to call watering down the Kool-Aid. So we're trying to throw some more fluid in there to kind of water down the concentration of that sugar. But once again, as always, the old fallback, you will need to follow your local protocols. And then O2 and IV fluid therapy per protocol for patients who are hyperglycemic. So, if you're told to give a 250 bolus, but you got to watch out because these ladies can have some issues with fluid retention as well as fluid overload. So you just got a lot of different things going on. So you want to be very cognizant if you are giving some fluid challenges to mom and her condition. Respiratory disorders. So shortness of breath or general dyspnea. One of the most common complaints of pregnant patients. Now, a lot of it, as you can imagine, is because of everything that we talked about. Remember, we talked about how the whole abdominal cavity and everything starts shifting. Diaphragm starts pushing up, making room for baby, all these things. So that's going to cause some problems, as well as you have some hormone-related anatomic changes to the respiratory system. So the hormones, when we start talking about the progesterone and all that releasing, that's when you not only have the physical changes that are happening, but you also have these hormonal changes that are causing things to happen. So, it can become quite uncomfortable and hard for some of these gals to breathe. So asthma is a common condition that complicates pregnancy. It could be a pre-existing illness or even occur for the first time. Acute attacks may lead to progressive hypoxia. Now, if that's true and they start becoming hypoxic, remember, what goes on with mama goes on with baby. So if mama is hypoxic, baby is hypoxic, more than likely. So we need to make sure that there is not going to be many, if any, hypoxic episodes in these type of situations. Respiratory disorders, so maternal asthma complications, premature labor, preeclampsia, respiratory failure, vaginal hemorrhage, eclampsia. These are all complications of an asthma attack. Fetal complications, so we can have premature birth because a baby gets stressed out and the body's just like, whoop, time to go. Low birth weight, growth retardation, even up to and including fetal death. So, it's a pretty big deal, man, when we're talking about asthma and talking about hypoxic episodes. Hang on one sec. All right. Hyperemesis gravidarum, or the old persistent nausea and vomiting. So this is a condition of persistent nausea and vomiting during pregnancy. It's much more serious than morning sickness, especially during the first several weeks. The problem with this is, as you see, it can lead to dehydration and malnutrition. So this prolonged vomiting obviously is going to tax the body and start losing fluids and nutrition and all of that. The exact cause is unknown, but it's possibly from a few different things. Some increased hormones, stress, GI system changes. Now, it is most common in first-time pregnancies, multiple gestations, or obese women, and then symptoms include severe and persistent vomiting for more than 3 or 4 times daily, projectile vomiting, it sounds awful, consisting of bile and sometimes blood, severe nausea, pallor, and even jaundice. So pre-hospital treatment, as you can probably imagine, of kind of what this is going to do, we're talking about malnutrition, so we probably want to make sure we're checking a blood glucose level, giving a little bit of fluid, administering the first 250 of fluid, administering diphenhydramine if protocols allow, 10 to 50 milligrams IV, deep IM. Contraindicated if the patient is taking MAOIs. And then you can even move on to, you see, ondansetron, IV, we're talking about Zofran, right? So make sure you're familiar with Zofran, IV or by mouth if your protocol allows it. That's what I think most people are doing. Some people are still using Benadryl. Remember, Benadryl, we talked a little bit about it before. It can be a really good potentiator with your pain meds, as well as it will decrease that nausea and vomiting secondary to some of your opiates like morphine and fentanyl. But check orthostatic vital signs. So we're wanting to make sure that they're properly fluid hydrated. So standing up versus seated, those kind of things. And then, of course, transporting to the local hospital. Renal disorders. Kidneys increase in length and the ureters get longer, also get more curved, wider, a lot of different things. Excuse me. Changes increase the capacity but can lead to urinary stasis and urinary tract infection. So this could be mild, or it can lead up, but if it progresses, it can lead up to low fetal birth weight, retarded fetal development, premature labor, intrauterine fetal death. So a lot of really bad things. So everything kind of needs to work right in this scenario, right, for these things, for these little guys and gals to come out properly. Uterus puts pressure on the bladder, causing increased urinary frequency. So another thing that we see a lot, short of breath, gals needing to go potty a lot. So if the patient has pre-existing renal disease, she may experience a compounding of the problem. So, things can just if there's already issues, things can just get worse. And even if there is no existing renal disease, the patient may develop renal malfunction or failure from hypertensive disorders or other conditions. RH sensitization. So we're talking about the blood stuff. If the mother is RH negative and the father is RH positive, the fetus may inherit the RH factor. So we're talking about that as the fetal blood can enter the woman's circulation and produce a maternal antibody to the factor if we're talking about the negative and the positive. It's normally not a problem in first pregnancies, but in subsequent pregnancies, the antibodies will attack the fetal red blood cells because it's seen as foreign proteins. Now, the bad thing about that is what can happen, which is death of the fetus. So we're talking about RH sensitization. Infections, so UTIs, streptococcus, whatever, something about algae. Pretty sure it's not algae, but is passed to the newborn. It can cause a lot of different problems. So what can happen is you have these viral and parasitic infections. So early pregnancy infections can affect organ system formation. Later can cause everything from neurologic impairments, growth disturbances, heart and respiratory conditions. So most commonly encountered infections include the varicella zoster virus or the human parvovirus B19, listed as 5th disease, not sure what that is. Toxoplasmosis, a whole lot of different stuff. So UTI, group B, streptococcus, leading cause of life-threatening infections in the newborns. This infection here that we see here, whatever that is, it lives in the genitourinary and gastrointestinal tract of healthy people. So this bacteria can proliferate during pregnancy, resulting in a number of things. Your UTIs, uterus infection, even stillbirth though. But if it is passed to the newborn, it can cause some really bad stuff. Respiratory problems, pneumonia, septic shock, and even meningitis. Human immunodeficiency virus. So pregnant women may infect the infant during the birthing process with this. Talking about HIV, right? An HIV positive woman can take meds to control the infection though, and hopefully if mom is aware of this, that's what she would be doing so that infection is not passed on to the infant, because what a great way to start is in life is with that. Cholestasis, if the bile cannot flow normally, it builds up. Hang on, let me back up. So this is a disease of the liver, and it can occur during pregnancy. So what happens is hormones slow down or they completely block the normal bile flow to the liver. If bile flow can't flow normally, it builds up in the liver and spills into the bloodstream. So that's a bad thing, obviously. So symptoms, profuse painful itching, particularly in the hands and feet. That's the most common symptom. Fatigue, depression, nausea, right upper quadrant pain, and then even color changes and waste elimination. So dark urine, abnormally colored stools. High risks include carrying multiple fetuses, a familial history of cholestasis, previous liver damage. Now, torch syndrome. So we're talking about toxoplasmosis, other agents, rubella, cytomegalovirus, and herpes simplex. So these are infections that can pass through the placenta from the woman to the fetus or to baby. So I'm going to let you guys read those. Now let's move on. So pathophysiology of bleeding related to pregnancy. So abortion, now probably most of our thoughts when we think about that is kind of that elective thing, but by definition, what the body will do on its own is also called an abortion. So not just talking about an elective procedure, we're talking about what the body's doing. So what we see here is expulsion of the fetus before the 20th week of gestation. There's a lot of reasons the body does this. Sometimes it's to protect mom. Sometimes it's because baby just didn't form right and there's lots and lots of issues, kind of non-compatible with life stuff, so, or just the stressors and trauma and just a lot of different things. But you see there you have classified as spontaneous abortion, so a miscarriage, or elective abortion, and it's an intentional procedure. Habitual abortions, 3 or more consecutive abortions. Causes include ovarian issues, uterine malformations, cervical conditions, or infections. Threatened abortion. I think my notes are bad here. Here we go. Sorry. Threatened abortion. So abortion attempting to take place. It's characterized by vaginal bleeding in the first half of pregnancy, usually the first trimester is what we're talking about. It can progress to an incomplete abortion or it may subside. Treatment is usually complete bed rest so that the condition can be monitored, and the pre-hospital role, transport, and general supportive care, as you can imagine. Imminent abortion, spontaneous abortion that cannot be prevented. So signs and symptoms: severe abdominal pain from strong uterine contractions, vaginal bleeding, often it's very massive amounts of bleeding, cervical dilation. Pre-hospital goals, when we read about vaginal bleeding and being massive, is we want to maintain a good blood pressure. We also want to prevent hypovolemia in these gals. Imminent abortion, establishing an IV of normal saline, administering 100% O2, get you an ECG. emotional feedback, not feedback, support with rapid transport. And then, of course, we want to watch for signs of shock. If they're losing a lot of blood, then that's something we want to be mindful of and pay attention. Now, just a quick little side note. Obviously, these are going to be awkward calls. It's going to be uncomfortable for everybody, as well as can be very emotional, especially obviously for the patient, but it can be for the medics as well, because you're talking about life and death. So hopefully you guys have not experienced this. As someone that has, I've experienced this in my own family, of course, of running these calls. These can be kind of emotionally taxing and draining. So, what I've seen so many times, and have seen it myself, is you just become, what's the right word, kind of broken apart from it. I can't think of, disassociated kind of with the call. And that's what we do for survival. But, this is a time when someone at least needs someone. You don't necessarily need to say you understand what's going on or whatever, but at least be empathetic to somebody, Don't be a turd. It's so easy to be like that when someone is being a little, whatever, whether you feel it's over dramatic or whatever. But this is a time that you really kind of need to just at least be quiet and allow someone to talk and maybe provide a loving touch as well as, some comforting words. What you take that for whatever that means. So incomplete abortion, part of the products of the conception remains in the uterus. So vaginal bleeding will be continuous. And what we're talking about is essentially like an example of this. The fetus is expelled, but the placenta remains. So one of the things you want to watch for is signs and symptoms of shock. You want to make sure you're giving them some saline. Consult medical control if products of conception are protruding from the vagina. So, you definitely want to get a doc on board and find, hopefully you're going to be close to the hospital, find out what that next step is going to be. And then if you're able to, collect all the products of conception to give to the receiving facility. Missed abortion, so that occurs when the fetus dies during the first 20 weeks of gestation, but remains in utero. So the field management consists of emotional support and providing transport, as you can imagine. Hospital management, they're going to do some different things. So maybe you've heard D&C, so dilation and curettage. I'm not remember how do you pronounce that word, but a D&C, which is common, it's essentially going in and retrieving baby. So suspect a missed abortion if the patient has a history of threatened abortion with cessation of vaginal bleeding and a gradual diminishing signs of pregnancy. So movement, those heartbeats, those kind of things. You'll note that the following on your examination. So the uterus feels like a hard mass. Fetal heartbeat cannot be heard. What happens is these are usually caused by some kind of maternal disease or abnormalities, within baby or the uterus or the placenta, fetal chromosomes, all of those kind of things. So it generally precedes a spontaneous abortion is what we're talking about here. Septic abortion, uterus becomes infected following an abortion. History will include fever and bad-smelling vaginal discharge within a few hours after the abortion. So physical exam shows fever, abdominal tenderness, and the thing about this is it will progress to septicemia and septic shock in severe cases. So, obviously, much of the same things. I mean, the main thing that we're thinking about here is fluid, probably, and general supportive care, right? So, get you a line, 100% O2, throw them on the monitor, rapid transport, give them some fluid if they need it. Not a bad idea just to go ahead and give them 250 and kind of see what happens. Third trimester bleeding. So, the majority of vaginal bleeding is from abortion. The patient may report light or heavy bleeding, cramping abdominal pain, maybe even passage of tissues or clots. But this presents the greatest danger of hemorrhage, especially as the woman approaches term. And why is that? Well, there's a large volume of blood present, and then you also have these compensatory mechanisms that function as a result of pregnancy. So a pregnant woman can lose 40% of circulating volume before hypovolemia is apparent, just because of all these compensatory mechanisms that they have. All right, let's move on a little bit. Get out of the sad stuff. So, not that this is any better, but it's not quite as depressing. Ectopic pregnancy. Ectopic pregnancy is a life-threatening condition. So if you know that this is what's going on or you suspect it, this needs to be a big old red flag that's got raised up that this person could be sick or will become sick. It's a life-threatening condition where fertilized ovum implants somewhere besides the uterus. So fallopian tubes, a lot of different places. But the main thing is it's not in the uterus. So the fertilized ovum is often in the fallopian tubes. The fetus cannot develop the term. All normal signs and symptoms of pregnancy are present. So what you'll typically see is these people will present, or people, not ladies, will present with severe abdominal pain, and that's from the threatened rupture, as well as hypovolemic shock. All female patients of childbearing age with severe lower abdominal pain should be considered to be experiencing an ectopic pregnancy. So we want to treat for shock, provide rapid transport. So abruptio placenta, once again, reminders of things you've gone through, but this is a premature separation of the placenta from the uterine wall. Now, when is this most common? That would be in the last trimester is when this is most common. So causes include hypertension, trauma, drug use, alcohol use, diabetes, having multiple pregnancies. And the patient will report sudden onset of severe abdominal pain, no longer feeling the fetus moving, and then vaginal bleeding with dark red blood. Now, sometimes the blood does not reach the vagina, so no blood will appear. But when we're talking about blood, we're talking about a dark red blood. Physical exam. You could see signs of shock, often out of proportion to the apparent blood loss. So, and what we mean by that is if you remember what we just said, over on this page, we said that sometimes the blood does not reach the vagina, so no blood will appear. So maybe just a little bit of blood came out or not much. So you're thinking, this doesn't really make sense. This isn't in proportion to, what I've seen. That's because it's just not come out. It's still in there. So tender abdomen, rigid uterus on palpation, absent fetal heart sounds. So if the hemorrhage cannot be controlled after delivery, patient may need a hysterectomy. You're not going to do that. We're not going to go over that in the lab. So don't study up on it. Placenta previa, that is, placenta that is implanted low in the uterus and partially or fully obscures the cervical canal. So this is the leading cause of vaginal bleeding in the second and third trimesters. So the risk factors include high maternal age and multiparity. Complications include disseminated intravascular coagulation, or DIC, hemorrhage, low fetal birth weight, usually painless. Chief complaints usually painless, vaginal bleeding with bright red blood. So a second ago we talked about dark red blood, now or if any, but it would be dark red if there was. And now we're talking about bright red. So pay attention to those things. As well as the uterus is soft and non-tender, when if you remember before, we didn't have those same signs and symptoms, right? We talked about that it would not be soft and non-tender. All right, moving on to our assessment. So once again, OPQRST, if you're able to use that, always a good thing. When did it start? What were the woman's activities at the time? How much blood has been lost? Is there abdominal pain? OPQRST, identify any changes in orthostatic vital signs during the physical exam. That's a good time to note that. Indicate significant blood loss, which may be contrary to physical evidence. Look for positive Gray-Turner sign or Cullen sign. So remind yourself of what those were. Hang on one second, let me grab a drink. All right. Management of bleeding related to the pregnancy. So keep the woman laying on her left side. Remember we talked about that hypotensive, supine, I don't remember if it was disorder, but whatever, making sure that she is not pressing down, or baby is not pressing down on the inferior vena cava. So keep her lying on her left side. Give her 100% O2, provide rapid transport, give her an IV line if possible. These are good, if you think somebody is sick in a pregnancy patient, and I mean the sick versus not sick, not just they need to go to the hospital, but they're sick, I suggest putting in a large bore IV. So in the event, because they can lose a lot of blood really fast. So, minimum of an 18 if possible, and even 16 would be even better. Now, don't put it in her hand or something like that. Don't be mean. But it's a good idea always, in my opinion. Anybody you think is going to go to surgery, at least put in an 18. Anybody that has a potential to crash, put in at least an 18. Everyone will love you for it. And it's just good sound medicine, because most places will not push blood through 20 gauges because it will lyse the cells. All the pressure will cause the cells to lyse or basically blow up. So you don't want that. Obtain an ECG, and then use loosely placed trauma pads over the vagina to try to stop the blood flow. I shouldn't have to say this. You should already know this, but don't ever try to stop the bleeding by packing, because that is not a sound medical practice. That is very bad. So stages of labor, make sure you pay attention to this. This is something, as you probably, hopefully already imagine, is kind of important, testing as well as knowledge base-wise. So stages of labor. Labor is the mechanism by which the products of conception are expelled from the uterus. What a way to say this is what gets the baby out. So the length of time for each stage depends on whether the woman is going through her first pregnancy or if she has delivered before. So our first pregnancy was like 16 hours. Our last pregnancy was maybe 16 minutes. So, depending upon how many we've had, we got a whole herd of babies. So the more you have, the easier it gets for these gals. So now the first signs of labor, which often go unnoticed, include relief of pressure in the upper abdomen, increase of pressure in the pelvis. So you see things are moving. Relief of pressure up top, increase down low. Bloody show, you might hear those words, discharge from the vagina. First stage of labor begins with the onset of labor pains. Good thing to know, right? Early contractions come at 5 and 15-minute intervals. In the latent phase, the cervix begins to dilate and efface, so things get bigger and starts thinning out. The lower segment of the uterus is pulled upward and over the presenting part, resulting in effacement, thinning and shortening of the cervix. Now, the cervix stretches until it's wide enough to accommodate the baby passing through. Lasts until the cervix is fully dilated. Averages about 12 hours, up to 8 in multipara, and about 12 averages 12 hours in a first-time mama. You then have a rupture of an amniotic sac near the end of the stage. And that, my friends, is the first stage. Second stage begins as the head descends to enter the birth canal. Another thing you're going to need to know. The baby will undergo several changes in position to pass through the birth canal, so things start moving. You have internal rotation, so the head rotates with the face towards the woman's rectum. Third position that was the second position. Third position, extension, so the fetus is tilted, so the crown of the head is seen at the vaginal opening. So the body is doing these things naturally. So that's why I say this is the most natural thing that we can be a part of. The problem is many of our customers maybe aren't ones that take very good care of themselves, or they're high-risk pregnancy and all these other things. But generally, these things take care of themselves. You just have it may not feel like a luxury or a benefit to be there at the moment. It never did for me. I never really got very comfortable with these things. But you get the luxury of being there when someone is born. So then you also have rotation of the head to the side to align it with the shoulders. And then the final position, rotation of the shoulders that expulse the fetus or the baby from the vagina. So contractions are more intense and frequent now, talking about the second stage. We're talking about probably 2 to 3 minutes apart. The cervix becomes fully dilated and effaced. And when the presenting part of the fetus crowns, delivery is imminent. Now we're talking, it's a party. When you start seeing presenting parts, it's a party. So concluded when the newborn is fully delivered, 1 to 2 hours in nullipara, about 30 minutes in multipara, and much less. I had one where this gal was like 22 or 23. This was her 5th child, and she pretty much opened her legs and shot this kid out. And if you remember the commercial of Whitewater where the kid comes shooting out the pipe, the water slide with all the water, it pretty much was like that. This little baby came just shooting out. It was not a 30-minute ordeal there. This little guy just came shooting out. And anyways, so stages of labor. We already talked about that. Third stage, moving on, the placenta. So remember your first, remember your second. Remember the differences. You are going to need to know those. Third stage of labor, the placenta is expelled. Uterine contractions, the placenta separates from the uterine wall, first off, and then it's expelled because it's not just free floating in there. Uterine contractions squeeze shut the exposed blood vessels from where the placenta separated from the uterine wall. You have different hormones that also help do that naturally as a natural process that helps shut all of that down. Here you got some stages of labor. I'm not probably going to ask you to know all of these time things, but what I am going to ask you is to know some of the specifics about each stage, first, second, and third stage. Maternal and fetal response to labor. So during labor, the woman experiences an increased workload of the heart, increased blood pressure, pulse, cardiac output, increased breathing rate to accommodate, increased white blood cell production in response to the stress and exertion of labor. Makes sense, right? Because many times these gals are going to get a natural tearing, basically like in a natural episiotomy when baby comes out and it tears up a little bit, but those white blood cells are going to start fighting infections as well as just infections of other things. Preservation of fluids and electrolytes, protein breakdown and increased temperature from physical exertion. Blood flow diverted from the GI system resulting in delayed stomach emptying, loose bowel movements, nausea, vomiting, and diarrhea. I didn't have that on the right page, sorry. Fetal response. We're at 36 minutes. We're going to knock off a little bit more, and then we'll shut this one down. Fetal response. Decrease in the amount of oxygen and nutrients. So as much as it needs that to continue, all of that's decreased. Insufficient removal of waste from the fetus, a decreased fetal heart rate, and then you get some fetal, you can have some fetal acidosis. So nuchal cord, when the cord's wrapped around, multiple births, abnormal fetal position, respiratory conditions, shoulder dystocia, even other childbirth complications. So preparing for delivery, this might be a good place to stop. Yeah, this is probably a good place to stop. Start the next one. So that, once again, part 2 of chapter 41. That was about, another 40 or 50 slides. So next video, we'll be talking about delivery of baby. So you guys be good.